decrease fibrinogen level, and increase edema.
Okay. So he received a massive blood transfusion, massive amount of blood. What do you know about massive blood transfusion?
Okay. Massive blood transfusion, it can be defined as transfusion of 4 units of blood in 1 hour, or transfusion of 10 units of blood in 24 hours, or transfusion of a volume of blood that is equal to or greater than the recipient's total blood volume within the first 24 hours of admission.
Okay, thank you. You have informed us the latest definition of massive blood transfusion. Okay, that's fine. So what are the complications that could arise from massive blood transfusion?
Okay. In case of massive blood transfusion, there may be coagulopathy and electrolyte imbalance and metabolic alkalosis, and also fluid evolution. And the electrolyte imbalance includes hyperkalemia, hypocalcemia, and hypomagnesemia.
All right, doctor. So how could you minimize the requirement of these 8 units of blood?
Okay, it includes preoperative and intraoperative management. In preoperative, we can correct anemia and the use of hematinics, and intraoperative management, we can minimize the blood loss by maintaining hypotensive techniques and transfusion, and using self-service machine, and also by using of diaphragmatic glue and anti-fibrinolytic agents.
Okay. So how will you correct his DIC?
Okay. We can transfuse plasma and plasma.
Sorry, doctor, I didn't get you.
Okay, we can transfuse platelets, transfusion plasma, or cryoprecipitate.
Okay. So what are the treatment options for ruptured spleen?
In this case, as this is grade 5, nephrectomy can be done. And the treatment option depends upon the grading of the injury.
Okay, doctor. Okay.
Hello.
Okay, you can go on.
Okay. In 1, 2, and 3, conservative management can be given, and conservative management can be given, and we can follow up the patient by monitoring vitals and doing the ultrasonogram to see if there's any hematoma is increasing or normal in size. And in grade 4 and 5, hysterectomy can be done.
Okay.
And we can also consider
what are the consequences of hepatitis C infection as the patient revealed the past history?
Okay. There may be acute liver failure, or there may be liver cirrhosis, hepatocellular carcinoma, or portal hypertension.
Okay. So what are the consequences of okay? So how hepatitis C virus can cause liver cirrhosis?
Okay. In long-term effects, hepatitis C virus, there is inflammation and fibrosis of the. There is inflammation and damage of the liver cell that is replaced by the fibrous tissue that leads to fibrosis. And
okay, doctor. So why is this patient bleeding postoperatively?
Okay. This may be due to liver involvement, like due to hepatitis C virus infection, or maybe due to DIC.
Okay. So you have mentioned 2 causes. So which blood products could be given to minimize these kind of complications?
Platelets can be given.
Okay, that is great. So we have already transfused 8 units of blood. So why do you need another extra platelet for this patient?
Okay. To maintain the massive transfusion protocol.
Okay, just for protocol purpose. Any other thing you want to add?
For the purpose of coagulopathy, or to improve the coagulopathy.
Okay, doctor, let me simplify for you. Is there any blood cells that you want to transfuse the patient? You mentioned platelet. So which component the patient didn't receive from those 8 units of stored blood? That is also platelet. Okay, so why?
Sorry, I cannot understand your question.
Okay,
Hello.
so why do you want to transfuse extra platelet to this patient?
Okay. In this case, the patient has received only.
Okay, do you want to answer it later? Okay, what is opportunistic post-splenectomy infection?
The opportunistic
Yes, Dr.
post-splenectomy
Opsi.
infection is, yes, it's caused by the encapsulated bacteria like Haemophilus influenza, then pneumococcus and meningococcus, and also E. coli.
Okay, what are the vaccines will you give the patient post-operatively?
In postoperatively, we'll vaccinate the patient against the encapsulated bacteria like for meningococcus, Haemophilus influenza, and pneumonia.
Okay, doctor, we have finished all of our questions actually. So actually, whenever I asked about DIC, you asked again, should I define? So you can't ask the examiner like that. So another thing, I asked that if he received a massive amount of blood transfusion as the patient came after a road traffic accident, but how could you minimize the requirement of blood? So you have mentioned pre-operative, post-operative, and intraoperative like these hypotensive technique, but you don't have the pre-operative optimization option for you as the patient already is near to you. He has already presented after following a road traffic accident. So you can't have the pre-operative optimization option. Always try to say regarding the patient. So here you can use hypotensive technique, cell salvage, but you can't use the cell salvage technique because the patient is already hepatitis C infected. So you can't have that. So another thing you can mention that good hemostasis and reducing the time of surgery. Okay. So another thing you actually couldn't answer that we need extra platelet for this patient because stored blood can be stored for so many days, but platelet have only 5 days of shelf life. That's why the stored blood, that 8 units of blood that we transfused, didn't have any platelet. So that's why the patient is bleeding. That is the third cause that you could add actually. Okay, so that's why we need to transfuse more platelet, even though we have transfused 8 units of blood.
Yes.
So did you get it?
Yes, thank you.
Okay. So another thing, OPSI. Okay, I asked for OPSI in the elaborated abbreviated form, but you can't ask. Okay, OPSI. So don't like that. Don't do like this. Okay. So that's all about pathology. So Dr. Rifat, do you want to add?
Yes, thank you very much. This station, pathology itself is a bizarre station, I always think, but Dr. Nasir did very well throughout the station. So guys, always remember regarding the pathology, I have on aspect of the knowledge, I'd like to say always again and again, and I will keep telling you until you pass in the exam or appear in the exam. The only subject or only portion is the pathology you will get. You might get new station, but in case of anatomy and the critical care, you won't get any new station. So if you do have a proper knowledge on anatomy or critical care station, you will definitely get individually more than 50 out of 60 marks, and you will need only 112 marks to pass in the exam. So regarding pathology itself, pathology don't have any single station. You will get in your exam combining 2 or 3 stations. Like in my exam, I got testicular teratoma with blood transfusion or hematological disorder, 1 station. So just think, where is the testicular teratoma and where the blood transfusion is. So 2 things are totally different, but both things combined together and came in my exam. So you will get this type of station in your exam. So Dr. Nashid did very well. I would like to ask Dr. Nashid, could you tell me what is the treatment of the DIC?
Yes, we can transfer platelet and the parasitic and the filtering plasma, and also the specific treatment will be the treatment of the specific cause of the DIC.
Okay, Dr. Nashid. Uh, always remember fasting comes first. The cause of the DIC, until and unless you remove the causative agent and what is causing the DIC, if you don't remove the cause, whatever you do, you won't able to keep the patient alive. So the first thing will come in exam is to treat the underlying cause. Secondly, the things you are mentioning like fresh frozen plasma, cryoprecipitate, fibrinogen, factor 8, von Willebrand factor, those things are the combinedly given in the cryoprecipitate. So these things is very important. And regarding the treatment option or something else, you'll have to always mention, as Dr. Hastad is saying, permissive hypotension and other thing. So why platelet is given more than any other component? You guys know that the half-life, the lifespan of the platelet is from the Gannon. I am telling the reference from the Gannon is 8 to 12 days, and the half-life is only for the 4 days. So whenever you are transfuse so many bloods at a time, it's a massive blood transfusion. So you don't know the how much the blood has been stored. So it's better to give the patient plenty of platelet other than other components, because platelet is the cells that are destroying so earlier than other components. So platelet is given other than other component much more. So you did very well, but always remember you do have some marks in the portion for professionalism, but so you will have to increase your expression capability, how to answer, how to fluctuate the voice, so things. So you will have to work on it, and I know you very well from the very beginning of your preparation. You are doing very good. So keep practicing and just try to give your answer perfectly and smartly, and not in a monotonous way by fluctuating your voice. Thank you very much. Thank you, Dr. Hasnat. You are doing a great job.
Okay, thank you, Dr. Ripat. Thank you, Dr. Nashizeva. Actually, we can head towards the anatomy. So, unfortunately, our anatomy participant is absent today. So, is there anyone who wants to participate in the anatomy? Anyone? Anyone? Whatever it is, if you don't have any preparation, doesn't matter. Dr. Naida raised her hand. So, Dr. Naida, are you ready for anatomy, upper limb?
Dr. Hassad, I'm not prepared for upper limb. Just
okay, that doesn't matter.
Residual.
Actually, we all are aspirants. We
Dr.
all are here.
Dr.
to learn,
Hasnat,
actually.
I would like to share that Dr. Nahida is a famous teacher of my and
Please, why don't?
the phase I am conducting Mrcs part A,
Yes,
and she
yes.
recently did has taken her first or the upper limb anatomy class. So I think she will
Please, why
do very
don't?
well. Please start.
Okay. So Dr. Naida is a popular teacher, actually.
No, not at all.
So are you ready, Dr. Naida? Okay,
Yes.
let's get started. So look at the picture.
Yes.
Okay, so identify the bone.
This is humerus.
Okay, which sided bone is this?
This is left side.
Okay, are you sure about that?
Right. No.
Okay, so identify number 9 and number 10.
Number 9 is the laser trochanter. Greater laser towards it. Okay. Number 9 and number 10. Greater tuberosity and laser tuberosity.
Okay, are you sure about the tuberosity? Okay, let's move to the next question. Which muscles are attached here? 9 and 10.
9. By 9 there is teres minor. In 10 there is supraspinatus, infraspinatus, and supraspinatus, infraspinatus. Another I can't remember just now.
Okay, fine. And what about number 9?
Number 9. Number 9, there will be pectoralis minor.
Okay, are you sure about that?
No,
Okay.
not sure.
Okay. So which
Subscapularis, number 9, subscapularis.
okay, I'm taking your answer. So what is called number 6? Can you see number 6? Here it is.
It is the bicipital group or
Bicipital group. Okay, that's great. So which muscle is attached here?
Here, pectoralis major.
Pectoralis major. Okay, I am taking your answer. So, doctor, can you tell me the content of 6?
The content of 6, there will be tendon of long head of biceps.
Tendon of long head. Anything you want to add?
Really, I can't remember at this time.
Okay, so you mentioned about biceps. So what is the nerve supply of biceps?
Biceps is supplied by median nerve. Musculocutaneous nerve.
Okay, musculocutaneous nerve. So we can see the bicep jerk clinically. So what is the root value of bicep jerk?
Root value of biceps jerks is cervical 5 and 6.
Cervical 5 and 6. You can specify one?
Cervical 5.
Cervical 5. Okay. That is fine. So, doctor.
Yes.
Identify number 8. Here is 8.
Number 8 is deltoid.
So, what is the action of it?
It causes abduction of the shoulder joint up to 90 degrees.
Anything you want to add?
Actually, I can't remember now. At this time.
Okay. So, how can we test it?
Yeah.
So, what is the nerve supply of this 8?
Axillary nerve.
Okay. How can we test it? How can we test axillary nerve clinically?
Clinically. Axillary nerve for just I can't remember now.
Okay. So identify number
for sensory. Sensory
okay,
and
leave it.
motor.
We will answer this later. So identify number 13.
Number 13 is serratus anterior.
Okay. So what is the nerve supply of this?
Long thoracic nerve.
Okay. What will be the result if it gets injured?
Weaning of medial border of scapula.
Okay. What is the action of serratus anterior?
Serratus anterior will do internal rotation of the scapula, and yes, internal rotation of the scapula.
And pushing something upward, forward. Okay, Dr. Debolina raised her hand. Are you there, Dr. Debolina?
Yes.
Okay, so let me repeat the questions actually. So can you clarify us and as well as for Dr. Nahida? So can you identify the bone?
This is the right-sided humerus.
Humerus. Okay, that's great. So how did you confirm this is right-sided?
The greater tubercle and the lesser tubercle are facing anteriorly, and the head and the head of the humerus is facing towards the left side.
Okay, another thing, bicipital group is placed anteriorly. That indicates the right side. Okay, that's great. So identify number 9 and number 10.
Number 9 is the lesser tubercle and number 10 is the greater tubercle.
Okay, so which muscles are attached here?
Subscapularis number 9, and for number
Okay,
10
that's
it will
great.
be supraspinatus.
What about number 10?
Supraspinatus and
Supraspinatus,
interspinatus, and teres
teres,
minor,
minor.
actually,
Absolutely. All right, doctor. So what is called 6? This is 6.
6 is the bicipital groove.
Okay, what is its content?
The long head of the bicipital tendon in a sheath,
Okay.
Which is a continuation of the what is it called? Capsular extension, I think.
Another
Sorry.
thing you want to add? Any other content? Any vessels or anything else?
Yeah, not really. Brachial artery, maybe. Sorry, not sure.
Okay, so we'll answer that later. So, which muscle attaches in 6?
I'm not sure. Sorry, pass.
Okay, pass. So, you mentioned about biceps. So, what is the nerve supply of biceps?
Median nerve. Sorry, musculoskeletal nerve.
Musculo?
What?
Musculoskeletal. There is no nerve
No,
regarding that
exactly.
name.
Sorry, so
Musculoskeletal.
sorry.
Yeah.
Just
Okay.
help her, Dr.
Musculoskeletal.
Hasnath. Help her.
Okay. Leave it, doctor.
I have not read this topic
Okay.
since my first year.
That is
Sorry,
absolutely
so
fine. That
sorry.
is all right, doctor. Nothing to be worried about that. So, root value of bicep jerk, Dr. Naida already mentioned about that. That's C65. And can you identify number 8?
That is a deltoid.
Deltoid. So, can you explain the action of it?
Deltoid helps in elevation of her arm after 90 degrees. No, from 0 till
up to 90 degrees. Okay, that's fine.
Up to 90 degrees.
Any other
Abduction.
any other action?
And anterior rotation of the humerus.
Which kind of rotation?
Internal rotation.
Okay. Any other
I have not studied it. Sorry,
okay.
so sorry.
Okay, doctor, leave it. Okay. So, what is the nerve supply of 8?
Axillary nerve.
How can we test it clinically?
By asking the patient to do abduction from 0 to 90 degrees.
Sorry?
Asking the patient to do abduction of the arm from 0 till 90 degrees.
Any other test you want to do?
Sorry, I don't know.
Okay. So, identify 13, doctor.
Serratus anterior.
That is fine. What is the nerve supply of it?
Long thoracic nerve of bell.
Okay. What is the root value of that?
C5, C6, I think.
C5, 6, 7. All right. So, what will be the result if it gets injured?
Bringing of scapula.
Okay. So, what is the action of serratus anterior? Dr. Naid already mentioned that. We have another 2 pictures. Please stay connected. I need to correct the answer. This is right, actually. Right sided. Okay, we already mentioned. Number 9 is lesser tuberosity, and number 10 is greater tuberosity. Number 9 is attached with subscapularis, and number 10 is attached with other 3 muscles of rotator cuff. There is supraspinatus, infraspinatus, and teres minor. That would be the answer. Number 6 is bicipital groove, and here long tendon of biceps, long head of biceps tendon, and anterior circumflex humeral artery. Okay. So these are the contents of these, and here is latissimus dorsi is attached. We know a mnemonic lady between 2 major. So lady means latissimus dorsi, which is attached 6, And to measure laterally is pectoralis major, that is number 8, and number 11 medially, that is
Teres major.
teres major. That is great. So in terms of the action of deltoid, there is abduction from 50 to 90 degree, and internal rotation that causes anterior fiber of deltoid, and external rotation that causes caused by posterior fiber of deltoid. Okay, did you get it? So
Yes.
you already answered serratus anterior. That all are correct. Now come to the third picture, doctor. So identify number 17 and number 26. This is number 26. Oh, sorry. This is number 26.
I don't think I won't be able to answer anything about brachial plexus.
Okay, Dr. Naida, are you there?
Yes.
Okay, so you can try.
Yes.
What is number 26?
Number 16. Number 16 is
No, I asked you about number 26. This
number
one.
26.
Alana.
May I try? Yeah, Alana.
Yes, anyone can answer. Devolina can answer. Dr. Devolina.
I think it's musculocutaneous nerve.
Okay.
This is not.
Yes. What is number 17?
There's a median nerve.
I think number 17 is median and number
But these are
26
cords.
is
Sure, I didn't
These
get
are
you.
cords.
Okay. Just I need one participant for now. Who was the male voice? Dr. Mosharov, are you interested to answer that picture? Okay, so what are the root value of 17 and 26? This is 17 and this is 26. I think all of the participants got afraid by seeing this picture, actually.
Can I try, sir?
Yes, you can, actually, no doubt.
Okay, so I think number 17 is median and number 26 is ulnar. I'm not sure, but yes.
All right, great. So what are the root values of?
Okay, so the root value of ulnar should be C8 and T1, and median nerve root value will be C5, 6, 7, 8, and T1.
Okay, just in terms of ulnar, just add C7, 8, T1. Okay, that's fine. So
okay.
what will be the features if number 26 gets injured? Number 26, you already mentioned ulnar.
Okay, so there might be, in case of 26, there might be ulnar claw.
Okay, anything you want to add?
And also, no, I can't remember anything else. No.
Okay, so anyone wants to answer these questions? What will be the result or what will be the findings if number 26 gets injured?
Can I answer? Hello?
Hi, hello. Yeah, I can hear you.
Yeah, if ulnar nerve is damaged, there can be sensory and motor loss. In sensory loss, there will be loss of like sensation over the medial side of the forearm, and on the hand, there will be loss of sensation of first, fifth, and medial half of the fourth digit. On dorsal surface as well as on the palmar surface, and this will cause claw hand also, because there will be paralysis of intrinsic muscles of hand.
There is will be there will be wasting of hypothenial muscles and sensory loss. There will be medial side arm and forearm. Okay, that's fine. So, doctor, what are the causes of 26 damages in different levels? What are the causes of 26 injury in arm, in forearm, and in wrist?
Okay.
In the elbow is LV is a high variety ulnar nerve injury will cause by the fracture of the medial epicondyle, ulnar entrapment.
Okay.
And
what is the cause of ulnar injury in axilla or arm?
The penetrating injury, or traction injury.
Alf plexus, Klumpke's plexus.
Okay, doctor, I have taken this Klumpke's paralysis. Anything you want to add?
Yeah.
Okay, no one. So
also in case of breech delivery, I think.
In terms of breech delivery, okay, if there is hand pull-ups in case, but actually there are Klumpke's paralysis if there is any Pankos tumor from the apex of the lung, or any kind of cervical rib that also causes thoracic outlet syndrome that can also compress the lower trunk of brachial plexus that can get the injured ulnar nerve in this terms of patients. So in terms of wrist, there is injury is another cause, and another cause is ganglion cyst. Another one is Guyon's canal lipoma. These are the causes behind the ulnar nerve injury. So what is ulnar paradox, doctor?
So ulnar paradox is a clinical phenomena where if the ulnar nerve is injured in elbow, or the problem there will be complete.
So which muscles? Dr.
Flexor digitorum profunda.
All right, very good, doctor. So this is our final picture. Who wants to answer? Dr. Debolina, Dr. Mosharraf, Dr. Nahida. Okay, Dr. Debolina raised her hand. So what is this picture? Can you identify?
I did not raise my hand. Sorry.
Sorry?
I can try. This is picture of an angiography been done through the, I'm not sure, the brachial artery.
This is a digital subtraction of angiography denoting your subclavian, part of subclavian, axillary, and part of brachial artery. Did you get it?
Oh.
Doctor, can you repeat it again, please?
It's a DSA, digital subtraction angiography denoting final part of subclavian artery, axillary artery, and part of brachial artery.
Okay.
So identify the arteries level A to D. Anyone?
I want to answer. A is subclavian, okay, and
what is B?
B is circumflex, anterior circumflex artery.
Posterior circumflex.
Posterior circumflex, okay.
C
is lateral thoracic artery.
What is D?
D is brachial.
Okay, doctor, you got two of them right. Actually, anyone wants to answer this? Okay, I can correct. Number A is axillary artery. Number B is posterior circumflex humeral artery. Number C is subscapular artery, that is below the scapula. Number D is brachial artery, which is the continuation of axillary artery. Okay, so is the artery labeled A, that is axillary artery, is medial or lateral to its corresponding vein?
I don't know.
Anyone? Either medial or lateral?
That should be lateral.
Okay, all right. You got the right answer. So where the structure A begins and where does it end? Can you tell me the boundary of artery A?
Yeah, artery A is axillary artery. It begins at the outer border of first rib and
Okay.
ends at the lower border of teres major muscle.
Teres major muscle as brachial artery. Okay, fine.
And the continuation of brachial artery, yes.
Can you name the branches of number?
Sorry, I can't hear you.
Can you name the branches of number A?
Yes, so axillary artery, it has three parts divided by pectoralis minor muscle. Okay. So from the first part, we get the suprascapular artery. And from the second part, I think we'll get thoracodorsal artery and lateral thoracic artery. And from the third part, we'll get the subscapular and anterior and posterior circumflex femoral artery.
Doctor, what are the branches of second part? Did you mention?
The thoracoacromial artery, I'm sorry, thoracoacromial and the lateral thoracic.
Yes, that's the correct answer, not thoracodorsal. Okay, that.
Yes.
So, doctor, you mentioned about B, which is posterior circumflex femoral artery. Is there any structure that accompanies the artery?
Yes, the axillary nerve will be there along with this artery.
So, how does it get injured?
In case of dislocation of the humerus, they get injured.
Okay, any other form of injury?
In a surgical neck fracture of the humerus.
That's the answer, doctor. That's the answer. Okay, we have got all of the questions for anatomy. So, Dr. Rifat, do you have any final words to say?
Thank you very much, Dr. Hassan, for conducting so nice today, all the stations, but all the stations were quite good, but another anatomy station, I am very much disappointed with the candidates with the anatomy station, because I would like to share you that for passing the anatomy stations or for passing the knowledge portions, anatomy and the critical care is the main keys, but you will have to have very crystal clear knowledge, because all the pictures that are given in your traditional books, you won't get any picture from those books, not even a single picture from those books. So you will be shown so many pictures, so many cadavers from, I don't know where they got all those pictures, but definitely will be shown so many bizarre pictures, so many dissection. So all the pictures that most of the, apart from this picture that is shown on the screen right now, all the pictures that has shown by Dr. Hasna today are very known to us. The pictures previous one, the first one, everything that are given in our traditional books, because all the books are same, all the contents are same, though we are trying to collect few pictures from the some recalls and some I got some pictures from the Egyptian candidates. I'm trying to accumulate those pictures from in our anatomy sheets, but these pictures and the first one are the very common pictures, and these are from our books, traditional books. So you guys are not even correctly answered the any single thing perfectly, like the rotator cuff. You couldn't answer the though insertion origin was not asked, but insertion you were not able to answer the insertion. You were not able to tell the function of the deltoid, not even the biceps. But I don't know what is the lackings, because these things are so easy. If you are taught, I can assure you, if you are taught by me, you won't forget those things. Even just look at this picture, just look at the origin of the deltoid. Deltoid has three origins, like the front of the this is what is called, what is this bone is called, just above the six, what is called? This is the collar bones, right? Can you see, guys? Just answer with me. What the bone is this? Just above the six. What is this?
Yes, clavicle.
Right. And just lateral to the clavicle, what is this?
That would be acromion.
Exactly. And just behind the acromion, what is this?
That would be spine or
Spinous
Spine.
scapula.
Exactly. Just the
scapula.
three origin of the deltoid. One is clavicle, one is acromion, and another one is spine. Just right now, you pull just only from the clavicular head of the deltoid. What will happen to your arm? Just say me.
Internal rotation.
Exactly. What will happen if you pull by the acromion process, the muscle, just only from the muscles from the acromion
External
process?
rotation.
No, only from the acromion process.
Only from acromion process.
That will pull your arm, abduction, right?
Abduction.
Exactly, from 15
Acromion
to
process
30,
abduction.
90 degrees, from
And
15 to
spinous
90
process,
degrees, and
external rotation.
from the spine, the muscle which are attached with the spine, just if you pull from those portion, there will be external rotation. So it's not a big deal, guys. It's not a big deal. So just I can assure you, you won't forget who are the candidates right now here. And if you are if you are able to understand what I am trying to say, you won't never forget the function of the deltoid, I can assure you. So these are very easy, because if you don't have any crystal clear knowledge from this portion, you won't be able to answer the bizarre picture that will be shown in your exam. And one of my colleague who has passed recently FCS final part, the first chance he couldn't pass for consecutive 3 attempts. He failed for the 2 times, just only for the 1 marks. And one question he was asked in his exam to identify the subclavian artery, and that was his last question, and he couldn't answer this, and he has failed. And another attempt, he was just asked in the pathology station what is called sensitivity and what is called specificity, and he couldn't answer this. But after finishing the exam, he was just telling me everything at a time. But in that portion, you will be very nervous, you won't able to answer everything. So if you are confident enough, if you know very specifically how to answer, if you are very habituated with participating with the mock, then you will be able to answer the questions so perfectly. So thank you very much. I think you will be build your knowledge in anatomy portion by practicing again and again, and I will try to share some pictures if I get time, so that you guys can be habituated, because limbs, upper limb, lower limb, and head neck is the most important portion to for the Mrcs Osce exam. And I think Mrcs Osce exam is nothing, just a simple exam if you are very properly guided. Thank you very much. And I myself, Dr. Nahid Hassan Rifat, I am telling you that I am teaching almost more than 30,000 students all over the world. And right now I am on the Mrcs Osce field, and you will be guys surprised. So many foreign or nearby mentors just they're so surprised that I am on this field, and they are just calling me, wow, you are right now in the Mrcs field, and what will happen to us. So thank you, guys. I'm here to support you.
Hopefully we will rock it with everyone's help.
Everything. And I can assure, brother, if you are with me to support you every single aspect, and nobody, I won't let anyone to fail in the exam, and keep my word. And I will, inshallah, I will try my best to give my best effort to pass every single person of this session, and at a single time. And it was previously it was said that Mrcs is the exam for second timer, but I would like to change this speech. I would like to say, if you are properly guided with the best mentor, and you will be passed in the exam in a single attempt, inshallah. Thank you very much, participant. I'm very much proud of with you, especially apart from the anatomy. I'm very much pleased to have you guys. You did very well, but you will have to practice again and again in the anatomy portion. Thank you, Dr. Hasnat, and everyone. Please continue.
Thank you, Bhaiya. Thank you.
The anatomy portion was actually disappointing. Whenever you lose marks in anatomy, it will be very, very difficult to pass in the knowledge section. So this is anatomy is the only station where there is no marks for professionalism. You will answer just in one single or double word or 3 words, you will get full marks. You can obtain 20 out of 20 if you can answer it properly. And Dr. Rifat said that if you get more than 50 or 55, out of 60 marks, you will definitely pass in the knowledge part. There is no doubt about that. Pathology portion is just nasty. So you might have so many uncommon questions for that. And that's actually risky. And if you invest enough time in critical care and anatomy portion, that is enough, more than enough to pass actually in the knowledge portion. That's all we have for today. So any other concern from any other participants? So do you have any questions to me or Dr. Rifat Bhai? No one. It's already 12 right now at the middle of the night. So if there is no questions, I think we can finish for today. That's all. Thank you, everyone. See you next.
Thank you, Dr. Hasnat, and thank you everyone who has participated to this session. And if you found the session is effective, to encourage us, you can give a review in our group that we are just a true review of this mock. Thank you, so that we can continue this session. Thank you very much, guys. Thank you.